The Chair invites you to make your contribution. As Chair, I may ask that you are muted if you do not participate in this way. And so, apologies. I don't think we've received any, no late apologies. Thank you. Disclosable pecuniary interests. We've not received any indication of that. Has anybody got any pecuniary interests they need to declare? No, thank you, and nobody online. Thank you. So we move then to item 3, which is the minutes of the last 2 meetings held on the 20th of April and the 14th of May 2026. Does anybody have any questions with regard to those minutes? Okay. So I propose then that they be recorded as correct. And can I have a seconder, please? Thank you, Dawn. And those in favour? Thank you very much. So that's unanimous. There have been no public questions and no member questions. And so we'll move on to the next item. I can get to it. Which is the 0 to 19 and 25% public health nursing services, June 2026. Thank you. And so is it Anne-Marie and Naomi going to thank you, present together? Thank you very much.
So, my name's Anne-Marie Speak. I'm head of service.
Sorry, can you put your... and start again, please.
Start again. My name's Anne-Marie Speak. I'm the head of service for healthy population.
Can you just speak a little louder?
Public health.
Or closer.
So we're here to give you a bit of an overview of the 0 to 19 up to 25 SEND contract, which is includes health visiting, school nursing and family nurse partnership. So just to set a little bit of context, this contract was originally, and the service was originally commissioned directly by NHS England in 2015. The school nursing element came across to public health in local authority for commissioning, and then 2 years later in 2017 that was followed by the 0 to 5 health visiting service. In 2017 it went out to procurement and it was combined into a total contract with all services combined under one heading. So it is a public health nursing service, so it says what it is on the tin. I'm going to hand over to Naomi, who's going to set the context for where we are now with the service and our next steps.
Thanks, Anne-Marie. Just by way of introduction, my name is Naomi Roach. I'm the Healthy Population Lead for Shropshire Public Health, working with Anne-Marie and responsible for the commissioning of Public Health Nursing Service in Shropshire. So just to give you kind of an overview in relation to the purpose of this presentation, obviously wanted to give an overview of the service, talk you through the existing contract and how we approached awarding that contract and what our future plans are, including the recommissioning of the service. As Anne-Marie said, Public Health Nursing Service is a mandated public health service, so it's funded through the ring-fenced public health grant. It accounts for about 1/3 of the total public health grant. The contract value is just over 5 million now due to the recent pay award, Agenda for Change. And the framework for delivery of the service are outlined in the Healthy Child programme, which you can find online, and it outlines the responsibilities and core elements of the service. As Anne-Marie has said, it is made up of health visiting, school nursing and family nurse partnership. It is an integrated service, as Anne-Marie has said, and the approach for public health nursing is providing universal, targeted and specialist services for children, young people and families across Shropshire. Just to give you a little bit more insight and detail into the 3 core elements of the service. Health visiting offers for children aged 0 to 5. Currently in Shropshire there's about 2,400 births on average a year. So the service itself and health visiting is supporting about 13,000 babies, and they're delivering that support from 5 locality bases and face-to-face in families' homes. School nursing supports approximately 34,000 children and young people in about 164 education settings across the county, and these services are offered for our children both by text, by phone, and in person in schools also. And our Family Nurse Partnership provides intensive support for young parents, so that's eligible young parents with additional vulnerabilities, with a maximum caseload of about 100 families. And that's really about focusing on improving the maternal, infant and child outcomes by working with mum and dad where appropriate and where possible, and with the wider family. So the service is defined as well through the Healthy Child programme guidance. The core delivery includes the mandated contacts that are set out in the guidance. In addition, in Shropshire, we have open access clinics where health visitors are available through our community and family hubs for families to access support. The National Child Measurement Programme, NCMP, is delivered by the school nurses in reception and year 6 in schools. Health education for schools, safeguarding and targeted early help. And obviously all of this support is aligned with local need and carries out the statutory public health responsibilities. The service model, as I've explained, is locality based. So our health visiting FMP and public health school nurses are available across the county and accessible, and have very good relationships and communication with the wider partners. So our schools, early help, the wider health system as well, and family support services. So during 2025, we took a step to recommission the service because the contract was coming to an end in March of this year. As part of the approach that we took, there was a strategic review and options appraisal carried out to ensure that we followed the most appropriate route for recommissioning of the service. We also used previous market engagement for the service, which gave us assurance in relation to the proposed steps that we were taking in relation to the recommissioning of the service, and also to understand what the market capacity and provider interest would be. So in all, before we started the process, the retendering process, there was a very structured review of the service and the options and routes available to us before we went forward. The decision that was made and supported by a wider group, including Leadership Board and our Joint Commissioning Delivery Group, was to take the NHS provider selection regime route for direct award. And what we needed to do in order to utilise that approach was to take a really robust assessment of the service based on very specific framework and outlines to ensure that there was evidence there that the existing provider, that we were assured that the existing provider was delivering on the service, and that they were positioned in a strong enough place to continue to do that. In addition to that, a review, an assessment that was carried out, supporting evidence was asked of the service to back up, I suppose, and just give us that assurance again as evidence. So the kind of next stages to that, after we'd done the assessment and looked for the evidence, was that independent review, so that it wasn't a process that in public health we just carried out alone. We worked with our colleagues in education, with the wider health economy as well, and safeguarding teams to ensure that they felt assured also that the approach and the recommendations that we were making were supported and validated. And equally aligned with the local authorities' priorities and the system priorities to support families and young people. Thank you. The outcome of that provider selection regime assessment was that the decision was made and was upheld to use the direct award process C to award the Public Health Nursing Service contract to Shropshire Community Health Trust, who were the existing providers of the service at that time. Following a review of the updated guidance, it became apparent that we were unable to award a 3-year contract and had to award an 18-month contract. And the reason for that was the guidance, the updated guidance in PSR meant that you cannot award or use the process to use direct award if the contract value, the lifetime contract value exceeded 25% increase. So it meant that we couldn't do three years, we had to do 18 months. So that contract is now in place. It was awarded in April of this year and expires in September of next year. So that was the re-award of the contract, and that's where we are now. So just to support the rationale and reasons behind why that direct award was made following the assessment and the evidence that was provided, it obviously creates and gives us quite a lot of continuity amongst rising demand across Shropshire in families. There is limited funding for the service and obviously additional national pressures. So OHID's expectations have increased. The wider children's reforms and working together legislative changes have a significant impact on the service itself and the development of the Family First programme as well. But again, from an assurance perspective, the route that we followed had established governance and assurance processes. So at all times, the award and the route that was taken was endorsed by the Joint Commissioning Delivery Group and supported by Leadership Board based on the options appraisals that were shared. So the next steps in terms of where we go now, as I've said, the existing contract finishes in September of next year. We have started, and it's actually live at the moment, provider market engagement. So that's gone out to market in relation to just testing what provider appetite is. And that insight from that pre-market engagement will inform and help shape our next steps in relation to an open procurement process or what route we take. Discussions and appropriate discussions have been had with the provider. We've established a recommissioning oversight panel, which is made up of both internal local authority and external partners, including education. So we've had some interest from primary and secondary schools to be part of that oversight panel, including colleagues from the ICB. And from the local authority as well. So from a safeguarding perspective, from children's social care, from early help. And the idea is that that oversight panel is in place to guide and ensure that the steps we're taking are robust and accurate, but also that we're ensuring that we have the voice of all stakeholders involved in the process. So as I said, the pre-market engagement is now live. We've got a timeline in place in relation to that recommissioning process, and we will be looking to come back to JCDG and inform Cabinet in September in relation to our next steps and what that might look like, and obviously look for that support to move forward and insight in relation to that partnership voice. There's also, as part of that plan moving forward, some discussions about how we ensure the voice of families is also heard in that. As I've mentioned, there are the open access clinics currently running across Shropshire, as well as some infant feeding peer support groups as well. So we will plan to engage with families through those routes to ensure that their voice is heard. In relation to the risks and mitigations, we are acutely aware that there are workforce pressures which can in fact impact on delivery. National reform expectations are quite large. There's possibly nationally the biggest reform around children's services coming into place, so we need to be really aware of that. And the contract we have in place at the moment limits some change. But in terms of the mitigations around that, we have quite robust contract monitoring in place, and that contract monitoring is also includes our wider stakeholder partners. So it's not something we just do as a public health team, it's something that we include partners in to ensure that we've got that assurance and oversight. We've also got some priority area improvement plans in place with the service, so we are focusing on things like the Family First Partnership, that national reform, and those key areas that we need to really focus on. And the recommissioning programme in itself is a mitigation around that contract change to ensure that we're reflecting needs of children and families, that we're improving outcomes for our children in Shropshire, and also aligning it with the priorities both locally and nationally. So the key messages really, this is a critical statutory service. It is under pressure. We've got a lot of activity within the service. We're very, very aware of the pressures in terms of not just the workforce, but again, that national and local transformation. The provider selection regime ensured safe continuity of the service, and we're quite assured by that, but the recommissioning of the service is also a key opportunity for us to ensure that the service delivery is aligned with our local need and priority areas.
Can I just add, just before we finish there, for anybody that goes away and looks at the Healthy Child programme, the Healthy Child programme itself isn't just a house visiting and a school nursing and a local authority responsibility. It's actually about partners working together to deliver the Healthy Child programme. So I just didn't want anybody to go away and read it and think this is everything that should be being done by local authority.
Thank you very much. Before opening it up to councillors, thank you very much for the presentation. It's very, very clear. As you say, that there are a number of pressures on the service, which I'll come to. But I just wonder, the independent structured review that took place, is that published?
It isn't necessarily something that we have to publish. I
understand that.
Sorry?
I understand that.
So no, it isn't published. It's not something that we tend to do as part of the provider selection regime or about any other procurement process, really, because some of it is commercially sensitive.
I understand that there may be parts of it that are sensitive, but clearly, if this is a health overview and scrutiny committee, I think it would be beneficial to have as much information about independent reviews that are done in relation to the services that are being or will be provided. And so I don't know if you could take that back.
We can absolutely provide a summary of it and an overview of it. But as I say, from a procurement perspective, it's not something that we would publish completely, particularly in the public domain because of the commercial sensitivities. But absolutely, we can do an overview.
Thanks, Anne-Marie. And then moving on to the actual procurement, are there many providers that are going to be in the market for this type of activity?
That's a very difficult question to answer. When we last did the market engagement, we only had a couple of providers that came forward that could potentially deliver the whole of the programme, and we have no intention of splitting it down into lots because it makes it too piecemeal and then you don't get consistent pathways throughout. So there were a couple of providers that showed an interest. One of the things, or a few of the things that come out from providers when we were doing the pre-market engagement was the level of funding that's available and the expectations within the service specifications and the national expectations. There is quite a heavy responsibility in relation to 2P for this sort of contract, if you think of the amount of staff that would be involved that would then need to 2P over. And also premises in Shropshire is another barrier and a challenge for any new providers coming into Shropshire, because actually sourcing premises, which would then potentially mean for new providers that they would need to have additional resources within the contract to enable them to secure premises within Shropshire. So there are some challenges, but hopefully through the pre-market engagement we can start to address some of those challenges and think about how we might be able to improve the market engagement and the ability for wider partners to come forward.
Yes, I mean, as you say, the status quo is difficult to overcome for a newcomer to the market. And I'd just like to ask two further things. You've talked quite a lot about health visitors and school nurses being the backbone of this provision. But we know that the number of health visitors nationally has halved since 2017. There were 10,200 in 2017, and there are now, I think, just over 5,000. So that's a substantial reduction. And in relation to the quality of services provided, the need to deliver the National Neighbourhood Implementation Plan and the 10-year NHS plan, are there any moves to increase the number of health visitors? Because, as you also know, there has been a lot of discussion about the concerns of health visitors themselves, who have what they believe is an extremely onerous workload, with up to 1,000 children per health visitor, against a background of 250 in most of the European countries. And the second thing is with regard to the school nurses, where the schools themselves report a rapidly increasing need for assistance, particularly with mental health issues, and that most describe the current level of service as not really meeting the need in any way. And have you considered this?
So if I can take the health visiting numbers first, if that's okay, Chair. So in relation to health visiting numbers, I think it's also important to note that in 2015 to 2017, nationally there was a call to action in relation to increasing the number of health visitors. So of course we saw a really big peak because of that call to action. However, a number of those health visitors didn't stay in service once they'd qualified. So despite that call to action, nationally, there has been a shortage in relation to what they call specialist community public health nurses. So that's the acronym. It's called SCUFN, and it's the specialised training that health visitors and school nurses undertake to become practising in that area. So there are a number of things that have impacted on that. Some of that is around the pathways into health visiting and also the pathways into nursing in general. So anybody that goes to become SCUFN trained has to be a registered nurse in the first instance. And as you know, sort of in the last 10 to 12 years, the pathways for nursing has changed, whereas previously you used to go in as a general nurse and then could specialise in any area, whether that be adults or children's. Now people have to specialise and name what they're going to do beforehand. So we've got a separation between adult and children's nurses. So you've almost before you've even started, halved the number of nurses that could potentially go into health visiting. There has been a reduction in places available in universities, but also that decline in people actually wanting to become SCUFN trained as well. As far as the service goes itself, everywhere nationally has seen a reduction in health visitors and the number of trained and the number of people leaving the service. And we did see a considerable decline nationally during the COVID pandemic, because a lot of the SCUFN trained nurses were redeployed into other areas. Stress, high caseloads and things like that meant that we saw a decline in health visitors. Locally as well, we also had a number of health visitors that were coming up to retirement, so no new health visitors coming through. We have bucked the trend with our service nationally. So Shropshire Community Health Trust have done a fantastic job at recruitment and also providing a grow your own type programme. So they are training and continually training, and as part of the workforce development, what they are offering is a 12-month placement with them as a general nurse to support the health visiting service, which then enables them, if they wish to go on to the SCUFN training after that 12 months. So giving people the opportunity to try it, to see whether they enjoy it and want to continue, whether that be in health visiting or school nursing, that is an option that is available.
Thank you. And sorry to interrupt, but do you have the numbers of full-time or whole-time equivalents for both health visitors and school nurses?
We can provide those for you, but I don't have them off the top of my head.
I'm sure you'll tell us what plans you have to improve recruitment and what vacancies are on?
We have no vacancies within the service currently in either the school nursing or the health visiting service. They are fully recruited to
your establishment level, but perhaps not at the level that there was before. So again, you know what I'm asking.
Yeah, I do know what you're saying, but unfortunately the funding envelope is the funding envelope, and without additional investment it would be really challenging to increase the number of health visitors or school nurses at this stage.
But it might be fertile ground for redistribution of resources from secondary to primary and community care.
Absolutely.
In accordance with the 10-year NHS plan and the National Neighbourhood Implementation Plan.
Yeah, and those are the conversations that we're having in relation to whether there are any opportunities for joint commissioning going forward to actually do that left shift into a prevention type programme, which obviously the health visiting and school nursing programme absolutely is a prevention programme.
Thank you. It'd be great to be informed about that and perhaps participate if we can. And so with regard to the school nurses.
Yeah, so from a school nursing perspective, absolutely. School nurses aren't specialist mental health practitioners, so although they provide additional support in relation to prevention and early intervention, they aren't specialist mental health practitioners. So the support for mental health actually sits within the CAMS contract, and there is an ambition to increase the number of mental health school support teams within that contract and nationally, so that every school has access to a mental health support team going forward. Obviously that's going to take some time to actually implement completely so that all schools are covered, but each year there is a new cohort of schools that are enrolled into that programme.
Thank you very much. Sorry to hog the questions so far. So have we got anybody who would like to ask questions? Councillor Colin Stanford.
Thank you, Chair, and thank you very much for the presentation. If I may, I've got 3 questions. One relates to the family nurse partnership you mentioned, which clearly does very important work, and it appears to be restricted to a maximum of 100 families, which seems a rather arbitrary number because human nature being what it is, the numbers might be less or more, I guess. So I just wonder whether there's any flexibility on this in any way, and perhaps bearing that in mind, it would make sense to me at least, given the restraints on budgets, that this type of intervention for families generally perhaps could be more targeted in any case. It would, whilst we know there are difficulties in all families, clearly by nature of the family nurse partnerships, some families require more help. So it would make sense to me to target as much of your resources as you can. So that's just an observation.
Can I answer that one first before we go on to the next one? Otherwise I've forgotten the first one. That's absolutely fine. So in relation to family nurse partnership, it is a targeted intervention, and it's a targeted intervention for young parents. So it's for those young parents where mum is 19 years or under at the time of her booking appointment when she goes into maternity services. So it is already targeted. It's targeted around that cohort because that's where the evidence base sits. So the programme, all of the evidence base is around young parents. The reason it's 100 is because they can only take 25 per whole-time equivalent per family nurse, and that is the number of family nurses we have, and that was done on the calculations of our young parents' numbers at the start of the programme. It is something that we manage and we keep an overview and review of on a regular basis. When it first started, Family Nurse Partnership, it was an intensive visiting programme throughout pregnancy and up until the child was 2 years old. As the programme has developed, there is now an opportunity to graduate, because that's what they call them, is graduate the programme earlier. If they are meeting all of their outcomes, they've got really good support around them, and the family nurse is assured that actually that family can continue to support themselves without that intensive visiting programme. So that gives us some flexibility within the programme to graduate early. So that 100 is constantly turning over, if that makes sense. So it's not a static number. Also, they will triage and prioritise people at the start of pregnancy. We have a number of very mature 19-year-olds that actually are in employment, have really good family support, etc., and will decline the programme because it is a consent-driven programme. So at the moment we are managing to manage those numbers quite effectively, and to flex as we need to. But absolutely take the point on board that, you know, as people become more complex and families become more complex, but the licence for the programme is for young parents only, and it doesn't go into any other targeted groups.
Thank you very much for that. This is more about the sort of procedural process. On your slide, which is called PSR outcome,
Yeah.
it says here a decision was upheld in February 2026 to award a direct award. And yet the following paragraph says, following a review of the updated PSR guidance, brackets, November 25. So it looks as though the guidance was there in November 2025, but the decision was made in February, somehow
Okay, so
not taking that into account.
No, so the process had already started, and we were going down the PSR 3-year contract award when the new guidance came out. So we continued down that process, recognising that we couldn't do a 3-year award, so reverted to an 18-month award based on the 2025. So the decision to upheld was actually on the decision to direct award at the 18-month length of contract.
Okay, thank you. And just very finally then, which comes to Bernie Bentinck's point, was you mentioned provider market engagement. And I sort of want to know what the provider, you touched on this, but I didn't get a feel for what providers are out there. Who are these bodies or peoples or organisations or businesses? So
majority of them are NHS organisations. They can be a combination of community or acute trust, depending on where their experience or where their service currently sits. So, for example, our public health nursing service sits within a community health trust, but in other areas it won't. They might sit within an acute trust and come under an acute trust umbrella. So some of them are based in NHS services, so as I say, the community or acute trust, but there are some voluntary organisations out there that have now got themselves CQC registered that can also provide the service. So they have to have that clinical governance because these are qualified nurses, they're registered nurses, so therefore have to have that clinical governance, so they have to have that overarching element of clinical governance within it, so they need to be CQC registered or part of an organisation that is CQC registered. So there are more sort of voluntary sector and different organisations coming on board, but it's a little more difficult for them to penetrate the market and get themselves into a position to do that.
Thank you very much. Thanks, Chair.
And if I could just add, theoretically, primary care networks and GP surgeries could also participate in this, theoretically. Provided they're CQC registered, yeah. So that might be food for thought for some of our audience. Councillor Dawn Houston, thank you.
Thank you. The point that you made about a 25% increase in the contract price, can you explain where that came from? Was that additional services that we were adding, or was that just the existing services that just got 25% more
so it's around the length of the contract, so you can't exceed more than 25% through the lifetime of the contract, and there was an 18-month contract already in place. So by the very nature of trying to extend it beyond the 18 months automatically meant that the lifetime of the contract was greater than 25%. Also, as part of the provider selection regime guidance, there's this arbitrary 25%, but actually you can't increase it through the lifetime of the contract of anything more than 500,000, and that is your ceiling throughout the length of the contract. So it was actually trying to extend the contract further that took us over that, rather than there being an inflationary increase of 25% within the contract.
Okay, thank you for that. Listening to your explanation of the market and potential providers, the barriers to entry seem quite extreme. So are we literally just being locked in? Are we fundamentally price takers?
Unfortunately. Unfortunately, I think that's the reality across, nationally, not just from a Shropshire perspective. But we do know in Shropshire that it's actually more difficult for people to enter the market in Shropshire because of the rurality. being able to provide and have the resource and capacity and the infrastructure to provide in a rural county. But premises is one of the real challenges.
What can we do as a local authority to help to remove those barriers to entry, to give us potentially a better pool to choose from?
So I guess there's something that we're already doing is around looking at the estates to see whether there are any estates that we can potentially offer new providers coming in. What we don't want, what we have currently with a provider is that actually they're based in all parts of the county rather than centrally based, and we really wouldn't want a provider that was just centrally based without having some outreach bases for people to work from. Purely because of the travel, you then end up with nurses that are actually travelling more than they're actually seeing people and families, and that's absolutely not what we want. So there is something there around us mapping the estates and trying to find what is available. So obviously they need to meet the expectations of clinical practice, so there is some elements there that does already make that more difficult to do. So being able to map those, and if you are aware of any premises that actually could be potentially utilised for new providers, that we could put those on the table when we're meeting with them. So the 2P is one of those things that we can't take out of the equation. It is what it is. But I think any provider now is fully aware of those, and any new provider coming in has probably already had the experience of dealing with that, and is maybe more so than when we went out to competitive procurement previously. So hopefully that will be less of a barrier.
Right.
There is something for us as well internally, and in consultation with members as well, is to actually the longevity of the contract, because if you've got a new provider coming in that actually needs to invest, they want to be able to invest for a longer contract rather than a 3-year or a 5-year contract, because if they're putting that investment in.
Okay, thank you. I'm a massive believer in the huge importance of the 0 to 5 period. And this is where, we're moving towards a prevention agenda. We really do need to be making those interventions in that phase. And yet, when you talk about the family nurse partnerships, it's only for the under 19s. Now, how do health visitors, when they go in and they know that that is a family in crisis, or that's a vulnerable family, or they need more support, I've had personal experience of a child not being identified as hard of hearing, and massively affected them at school because the mother didn't pick it up, and various things like that. And that's going to have potentially very, very long-term significant consequences for the child. What does this scheme that you're commissioning at the moment, how does that get dealt with? How do you, if they're not under 19, what do you do? How do they get into the system to get help?
So from a 0 to 5 perspective, there are the mandated universal contacts that every family is offered. I think it's important to say as well that that's 100% offer, but we can't make families take it up. We don't have any statutory legal basis for turning up at a family's house and insisting that they actually participate. But most people do, I have to say. Most people do want to engage themselves with the health visiting service. So in the mandated contacts, a developmental review will be done on the baby or the child, and also a review of the parents as well, so to make sure parental mental health is okay, and things in the household. Totally take your point. Those contacts are very, very few and far between, and so if it's not picked up at those, then how do we do that? And I think that's about how we actually manage the whole partnership around the Healthy Child programme, so that those children are being seen in other spaces, whether that's in a stay and play, whether that's within a community setting of something else, an earlier setting, that actually they know the routes in to refer back to the health visitor to say, actually, things aren't quite right here, and could you reassess this child, because they will absolutely do that. So the other element is if they've picked it up themselves, if they've gone in and they've picked it up, they'll put them on what we call a targeted pathway. So they won't just do the universal contacts, they will go back in, recheck, see how the child is developing, or how the family are supporting each other. And that may then lead to either referral into other services, or it may lead to a targeted piece of work that will be done by the health visitor or one of the support workers, whichever is appropriate. So that might be around early speech and language, for example, so thinking about actually how do we improve this, and then reassess the child again to see whether they're meeting those developmental milestones. One of the other reasons that we put the open access clinic in, although it's not part of the mandated service, is so that actually people have the opportunity to just drop in and see the health visitor, with a really destigmatised reason to say, actually, I just want to monitor my child's growth, so I just want my baby weighed, or so there's no stigma attached to it, but actually it gives them the opportunity to have that conversation. The health visitor will be there, will do the weighing, etc., with a support worker, and it gives them that opportunity to assess the child's development. Again, assess maternal mental health and well-being, and the opportunity just to bring up, actually, oh, I notice, I don't know, little Billy isn't doing such and such, does he do it at home, and have you noticed any issues, etc. So we're trying to open up those opportunities within those community settings for them to actually access and escalate those issues. We also have a really firm mandate at the moment to try and improve the uptake of the 2 to 2.5 year review. A lot of families, because they're in earlier settings, parents are back at work, etc., that's the one review that they are less likely to come forward for. So, we're really trying to push that and make sure that when children get to school, they are school ready. But it's how we do that as a whole community and partnership, really, as opposed to it just being around, the health visitors, and then the health visitors there to pick up that additional targeted support.
What metrics, measures, KPIs have you got in place to identify and see how well this is working to ensure that we start, because that children, school ready figure that I saw recently is bad. Yeah. So what are we doing to monitor, manage and make sure we're actually improving?
Yeah, so we have, with the mandated contacts, we have national KPIs and we monitor those through the contract. However, we don't just look at what the numbers are telling us, so we look at the case studies, we ask them through contract monitoring to give us the case studies around how they've supported. As part of the KPIs for the 2 to 2.5 year review as well, there is what we call an ages and stages questionnaire that is done with each parent and child, and it's parent-led, so they're asked to do it themselves in the first instance to try and assess what their child can do, and it will be, so it's split into 5 domains, and I won't remember the 5 domains, I'm sure, but they are speech and language, fine motor skills, gross motor skills, emotional development, and I told you I'd forget the 5th one, but it's social and emotional. So in those they've got, and it's an American ages and stages questionnaire, so they're not red, amber, green. In relation to flagging people, they're grey, white and black, which is a bit confusing, but if they fall in the grey or the black area, then it is an automatic referral for additional support. Whether that is additional support through a specialist service, or again whether it's a targeted intervention through the health visiting service, will depend on what level, which one of those areas they are not meeting their developmental milestones.
Thank you for your forbearance, Chair. But I've got so the people that are most likely to need the kind of interventions, help and support are possibly the ones most likely to either not engage with the process or over-exaggerate have a false perspective of their child's development. How do we deal with that?
So when I say it's parent-led to do it initially, but actually then when they go for the developmental review, that will be checked against what the parent's perception is. So a child will be asked, for example, can you thread a piece of string through play? So it's not sitting there saying, can you do this? But through play, they will give them, caster rings and things like that, and a piece of string to see whether they can thread. That's one of the things to look for fine motor skills, for example. They'll sit and chat as part of that contact and see how many words the child can say, whether they're hearing properly, etc. But if they are a vulnerable family and for any reason that they've been identified as vulnerable, whether that be through family circumstances or whether there's some parental mental health issues, they will automatically be on a targeted pathway, and as a result of that...
So that would pick up the non-engagers?
Yes, so they will keep going out. So although they'll be given the offer, they will keep being recontacted until they're actually actually that contact is actually undertaken. So they don't just leave them if they've been identified as vulnerable, or if somebody phones in and says, actually, you know what, I think they may have been on a universal pathway to start off with, but I don't think things are going according to plan, and the health visitors will do an additional contact and go out and reassess.
Thank you. Thank you. Thanks very much, Anne-Marie. Just to add before we go on to the next question, there is of course another route in which would be through the nurseries.
Absolutely.
And so I think it's important that these are mentioned, and I don't know whether you have any specific contact with nurseries with regard to referral processes, yes. and if you have any numbers about which come through in the various routes, but I think that would be quite interesting, and of course that's a further, hopefully a safeguard for young families that might otherwise slip through.
Yeah, so from an early years setting perspective, for children that enter an early years setting, they also have a review done, but it's usually nearer to the age of 3 rather than the 2 to 2.5. So when they enter the early years setting, the early years can actually contact the health visitor to see whether they've had their 2 to 2.5 year review, and with consent from the parents, they can share the outcomes of that 2 to 2.5 year review. So they can then see actually, was there an issue identified at 2 to 2.5 with that review with the health visitor? Did they not engage with that? And if so, then actually they can arrange for the health visitor to either redo it, or they can do a joint review together with the early years settings. For those settings that are in the 2 for You criteria, so those are the ones where our most disadvantaged children, which receive the funding for 2 for You at the age of 2, for an early years setting. We have a pilot programme going on where actually the health visitors and the early years setting will do the review together for those children that are on their registers for that, and that is working really well at the moment. So it's something that we would like to roll out and expand, but as you can imagine, we've got quite a considerable number of early years settings across Shropshire, so it may well be that we have to maintain that as a targeted programme.
Yeah, but that's a very useful programme, because of course these nurseries see the children every day or many days in the week, yeah. And so can do an ongoing assessment of their progress, and they could also ask whether the health visitors have visited for their statutory visits.
And they can refer directly into the health visitors if they've got concern about a family at all. They can refer it directly in. So there is a texting service, there's a single point of access email, and a single point of access telephone number. So anybody can contact through those routes and identify if additional support or information or signposting is required. Yeah,
but not yet at a fail-safe level.
I think that's difficult to quantify, but yes.
So Councillor Andy Davis, you've been waiting for a long time.
That's fine. Yeah, unfortunately, you just sort of answered my question, Chair, then. I was going to give Councillor Hughesman the solution for it, which you just identified. Having worked as a head for 20 years, the most effective way to identify children who are not performing is through the earlier setting. And it's not as complex. Yes, we have lots of PVIs with lots of schools having sufficient training for those staff across the board at a certain level can identify those sort of challenges young children have at a very early age, and it's the most effective way of doing it. You cannot rely on any other means of doing it. They come into schools, they're assessed straight away. And now some will have them from naught as well, some of these settings as well, from the babies as well. They can identify these sort of key issues. So having that prevention at the early years, putting the funding and the efforts into early years provision will solve lots of the problems which we do. And that's the most effective way of addressing this. Second thing, you've mentioned that you've carried out an evaluation of the current service, even though that data is not available to anyone. How have you identified the needs of schools, what schools actually want from this service?
So there are a few things that we do. So the public health nursing service, the school nursing element of it, I speak to head teachers and also look at the school population to see what the needs are. There is also some health needs assessment that are done by the school nurses in reception and I always want to say year 9 and it's not, it's age 13. So that is year 9 I think, isn't it? So it helps to start identifying the needs of the children. In secondary schools they offer drop-ins, so children and young people can just turn up and see the school nurse within those drop-ins, and they will get feedback from the young people themselves. But they will engage. It's not necessarily the heads. I think that's really important to say. It's quite often the pastoral care team that will be delegated to actually liaise with the school nurses.
Okay, so through this detailed analysis you've done, what are the views of schools regarding the nursing service at the moment?
I think a lot of it is around actually visibility. So, they will say that there is probably limited visibility of school nurses. The school nursing team is a really small team, and we've got 152 schools in relation to the school nursing team. I think there's also a little bit of a misconception around what the public health nursing service can actually provide and what their role and responsibilities are. So we've done a lot of work with head teachers over the last 12 to 18 months to try and dispel some of the myths around what is available.
Thank you. Because in the past, schools used to have an allocated school nurse, a named person.
Yeah.
And you could phone that person and they'll get back to you. That's diminished over the last 5 or so years, quite drastically. I spoke to a head teacher just last week regarding this. What involvement do you have with the school nurse? I don't know who the school nurse is. How do you contact the school nurse? I phone a number. There's an answer machine number. Someone will get back to me, perhaps, at some stage in the future. So that's the current reality in schools at the moment, speaking to various head teachers over the last 2 weeks. So that's the starting point. So if we commission a new service, we want to improve that service. So I'd like to recommend to the chair that at some stage in the future, once you've commissioned a service, this is brought back to scrutiny to look at how you're addressing the needs of those schools.
Can I just also say, the existing service has just, as part of the work we're doing, has just carried out a school nurse review, so a review of the service, and as part of that review, they've engaged with schools as well. So we are aware of what our partners, not just schools, but our early help providers also and partners, what their perception firstly is, so what their understanding of the service is, but also what their expectation is, and that insight will be fed into the recommissioning of the service also. Plus, we have representation from education as part of that recommissioning oversight group, so the voices of schools will be heard and taken into consideration in relation to that recommissioning process.
We've already carried out an assessment, haven't you, mentioned earlier on, of this current service. And is this the view coming through schools? Do they agree with me?
I would suggest they don't disagree, but okay. I would also say that there is a very definite misunderstanding of what the role and function of a public health school nurse is and what they can and can't do. So I think there's a balance between our responsibility to help schools understand that and also look at how, from a population perspective, we're meeting the needs and demands of those schools in a way that gets better outcomes for children.
Councillor Davis, I'd also be really interested to try and understand what numbers head teachers are using, because the single point of access has a person at the end of the phone, so it shouldn't all be in the main an answer phone message. They should be speaking to a person. So I'm just wondering whether
I'm more than happy to let you know the name of that school with a head teacher's consent.
Yeah. That would be really helpful.
Vice Chair was off instantly.
I just want to make sure that they're not trying to contact them in an old way.
We can arrange a meeting with this current head judge. I'm sure this person will be more than willing to speak to you. It's just trying you. We want the best for children in Shropshire. This is where we're coming from all the meetings we're doing here. And we want to try and improve it to the best way. So we can identify what issues are at the moment. We can support and help you in order to achieve us. But we need to be honest about the way it is at the moment. And it's then actually, when we had the school nurse linked, I appreciate what you're saying about different roles. There's so many different areas now as well. But, good issue. Can I phone a school nurse? Yes, it's, Charles got head lice, for example, or something like this. Even though, even there's little guidelines, and sometimes, but having a named person who you can speak to was invaluable.
Yeah, and schools do still have a named person. They will still have a named lead school nurse. So it's understanding where the communication is breaking down to that people within schools don't know who that person is.
Thank you, Councillor Davis. Can I just remind members that strictly it's supposed to be through the chair, the discussions, but I think in this setting we're quite relaxed so long as we don't go over too much time. Your comments bring us back to this independent structured review, that we have no knowledge of in terms of what the current service is. And I think it would be really important and beneficial for this committee to have some sight of the results of that review, taking into consideration those elements that might be commercially sensitive. But we're currently discussing a new contract without knowing what the old one was, without knowing what the baseline was, and also these numbers that we discussed at the first are important. Rachel.
Thank you. So I think there's a couple of things. One, we've said we'll take away and we'll share what we can, notwithstanding that it's commercially sensitive and that information. All of the KPIs are publicly available. There's a huge amount of information on the public health outcomes framework, so we can share that and make sure everyone's got access to that. Not all of the detail in the contract monitoring, but the high level, all of that information, as Councillor Eastman said, that's already, and it's one of our indicators within the Shropshire Plan and now the corporate plan. So absolutely can make sure that we share that in terms of the performance of the service, the current performance and the context around some of that. And notwithstanding, this was a service that was impacted by the pandemic and others, as you can imagine, particularly those children at that age. So we can take away the recommissioning. I think the purpose of bringing it today, what we wanted to do was absolutely make sure people were engaged and we get all of that feedback into the recommissioning of the service going forward. That's the real benefit of that. We can share absolutely the KPIs where we are. We've shared around the market engagement that's ongoing, and this is really around getting those wider stakeholder views. So as you can see, there's a lot of engagement already, but that was the purpose of bringing it here, to make sure we're getting those views and capturing that. Notwithstanding the link that was given in the initial part of the document outlines what the service does and is commissioned to do, and we are mandated to do by OHID, in terms of commission that service. What we want is the added value, and how do we make that really what we can do within Shropshire, within the context that we've got. So I think pointing committee absolutely to the key documents is what the contract is and what we have to do as mandated in statutory service. I think I'll be honest, there's been a lot of misconceptions around the service, and I think some of that changed in the pandemic and the requirements, because we had a lot, there was a lot of challenges, wasn't that, in terms of safeguarding this. So this is about being really clear. This is part of a service which is part of a bigger system of services. It doesn't stand in isolation. It's absolutely part of linking through to our social work teams, our education settings and others. And then we'll share with you those KPIs. We can share that today, because obviously that is being monitored in terms of the work that's been done and where we need to be focusing that improvement going forward, and making sure that the contract delivers what it should be delivering. I think the recommissioning of the service, as was sort of laid out, was really to give us stability, to allow us then to do this bigger piece, which is the real focus now, to make sure we get that service right for going forward, and that we'll have hopefully a wider market to engage with.
Thank you, Rachel. And understanding that, it's still really important to have this information on a regular basis. As you know, the ICB do a stakeholder update on a regular basis of their KPIs. And I think it would be useful for the Public Health Department and relevant other departments to do the same thing, so that we're not constantly scratching around for the information that could be available. And I know it's publicly available, but it doesn't mean to say that people that this committee can automatically easily access it.
Absolutely. Happy to bring a broader public health update. We usually do that annually for Scrutiny, which includes all the public health metrics. Just to say that obviously some of the key metrics are included in our corporate and Shropshire plan, which is why then that came through to committee. So absolutely not trying to cover anything or make it difficult for people to access the summary ones, the key ones. So the 2.5-year check, which is a critical one, is absolutely included and they're invisible. And then obviously there's a huge more detail that sits underneath that. But as I said, we'll make sure that's signposted clearly to committee.
Thank you very much. Unless there are any other... Councillor Neil Bailey.
Thank you very much. It's less of a question and more an observation, actually, that just listening to what everybody's talked about today, one of the things that came up about offering more competition is premises and actually getting people in Shropshire. We know as a local authority we're under very strict scrutiny because of our exceptional financial support. And therefore we are looking at assets and premises across the county and thinking what we might dispose of. So I suppose really it's just for all of us to keep that in mind. And if data is provided that, you know, a certain area, say South Shropshire, it would be more attractive if we could have a premises there for somebody, that information is given to us before. We certainly want to avoid the risk where we sell a building off and then go, actually, we'll just rent that back and it costs us X amount more money. So again, it's not sort of a question, but the more information that we are given, it helps all the decisions across all scrutiny panels. That was all. Thank you, Chair.
Thank you, Neil. And that just comes back to some of the ongoing discussions we've had about more member involvement in some of the aspects of the services that we're hoping to provide, and in particular the rollout of the 18 area hubs and the use of resources that might be available in communities but which may not be immediately known to either the ICB or the local authority officers. So I think that underlines that particular importance. Very quick in a second, but before I forget, can I just ask presenters, if possible, could you try to avoid acronyms and initials in presentations when it's not clearly obvious, because many of the recipients here are not health trained and they may not understand some of the terminology when acronyms are used in particular. Thank you. One quick one. Thank you, Dawn.
Sorry. You talked about nurses having to specialise right at the beginning of their training. Is that a yes or no? Just because I'm being told I've got to be quick. Yes?
There are two groups, adults and children.
Yes, so they have to specialise then. And this is coming from the top? This is coming from the government?
Yes.
So is this not something that they might have missed, the impact further down the line? And is this not something that maybe the chair could write about, because they are deliberately halving, potentially, somewhere around there, the pool of people that we have available to work in another sector going forward. So to me, that is a structural top-level issue that maybe you could address.
Understood, Dawn. However, there are no vacancies at the present time for these posts, and there's no budget to increase them at the present time. So
it's not for us. This is a general thing going forward.
Yes, and clearly it's a national thing. We have written before to the Secretary of State for Health. I'm more than prepared to write, but it will probably have greater impact if it comes from the Joint HOSC, and so I'll take that to the Joint HOSC to discuss writing to the Secretary of State for Health with regard to the difficulties in recruiting and maintaining health visitors and related posts. Very quickly. Thank you.
While we're talking about nurse training, I moved to Shrewsbury in 1993 to train as an RGN, and in those days you got a bursary. These days you get £52,000 worth of debt when you finish training, and it's worth pointing out that has a far bigger chilling effect than any sort of recruitment. In my day, you could also transfer between branches as well, which you may still be able to do. I don't know, I left nursing a long time ago. But is it still possible to transfer between branches?
As far as I understand, yes, it is still possible, but of course then that entails extra training and then potentially more desks. Sorry, yeah, so as far as I know, you can transfer across, but potentially, as you say, from a debt perspective, it means additional training at university, which then means, you're potentially inheriting more debt as a result.
A huge chilling effect.
Absolutely, unless you can get somebody to sponsor you in relation to a trust.
Thank you very much indeed. It's been a very lively discussion, and thank you to Anne-Marie and Naomi for fielding very difficult questions, and we look forward to receiving the answer to some of the points that we've discussed. But thank you very much for bringing it to us today. So if we move on, and this is just for information, we're not asked to accept it or respond to it. So we go on to the next item, which is the future of Health Watch. Thank you.
Morning, everyone. Thank you for inviting me to come along today. For anyone who doesn't know me, I'm Lynn Corley and I'm Chief Officer of Health Watch Shropshire. I haven't put together a presentation today, but I'm more than happy to send out any information you'd like about Healthwatch if that would be helpful. But I just wanted to give you a little bit of a context, because I'm not sure how much everybody really knows about Healthwatch. I think a lot of people think they know something about it, but maybe not everything. Obviously, I'm here because this is something I'm extraordinarily passionate about. You know, I'm Shropshire born and bred. My career has included teaching in further education, particularly most recently teaching health and social care to try and ensure that we've got, you know, a future workforce. But I've also been a children and family social worker in Shropshire, particularly in South Shropshire. So I suppose my interest really is in how social work fits alongside the work that the school nurses are doing, and picking up some of the things that you were talking about before. So just for context, so Healthwatch is actually a brand. The statutory powers of Healthwatch were created under the Health and Social Care Act in 2012, and that was as a direct result of the Francis report into the North Staff's experiences of care. And hopefully you've got some sort of understanding of the things that were happening in North Staffordshire at the time. So Healthwatch is the most recent iteration of something that has existed for about 50 years, which is an independent organisation to hear people's experiences of health and social care and then bring them to the ears of people who might be able to influence and make decisions about improving services. That is the fundamental basis of it. But we've actually got more statutory functions than that. So we also, it's really key to remember independence within the conversation that we're going to have. Because at the moment, the health bill, which came out, which is part of the NHS 10-year plan going forward, which was published last year, it took into consideration a report by Penny Dash, and her report was about removing quangos from the system. I'm not a politician. There's a lot I'm going to mention that I actually don't really understand very much. But Healthwatch was really wrapped up in something that which was much bigger than this, because we are actually very small fry, and we do a very different thing than those other organisations that were being talked about at the time. And we really do not want to be missed within this conversation. So the main functions of Healthwatch were to be an independent organisation who could bring constructive challenge to health and social care services using the voice of our population. And it's really important to us that we can hear from every single person using Shropshire services. Now, unlike a lot of organisations across this system, we prioritise face-to-face engagement. We do use digital, but we also use phone. People can email us, but what we try to do is go out and speak to the public. Right from the beginning, we were never given enough resources to cover a rural community like Shropshire. You know, throughout our time, we've had one engagement officer to do that. And my argument when I meet with NHS England, local MPs, is that right from the beginning, we were not given the resources to do a really brilliant job of what we're trying to do. And so any failings are partly to do with our capacity. So what we want to do going forward, which is what, as a network, because every local authority has got a network, is we're fighting for the independent voice going forward, but we also think that that voice it should not just be a token, it should be strengthened, because we know that in the NHS 10-year plan, there's a lot of emphasis on the importance of bringing people into these conversations to make sure that their voice is heard. And as an independent organisation, we can support people to do that properly. Because what I've seen since I've been with Healthwatch since 2015, I started as the interim view officer and I became chief officer in 2017. But what I see is people like, NHS providers, they start working with the public and very quickly members of the public become part of that organisation. They lose the ability to challenge and be objective, quite understandably, because they're forming relationships with staff. They understand the challenges those staff are experiencing, and so very quickly it becomes much harder for them to say, excuse me, but. And so one of the things that I really think this independent organisation needs to do is to support those members of the public to be part of this system so that we can bring that independent support to them and encourage them to challenge, but give them the knowledge and experience that they need to be able to do it effectively. So as well as providing that public experience voice, we also offer information and signposting to people about what their rights are, but what services they should be able to expect locally. And that includes across the local authority, the NHS and the VCSE sector. So it's really important that the organisation has local knowledge and the ability to work in partnership with all of those organisations. We also have volunteers. We've got I've got 4 part-time staff trying to do this job. Without our volunteers, that would be really, really difficult, and we always need more. We've got 24 volunteers at the moment who cover the whole of Shropshire, from Oswestry to the borders, to Ludlow, to Bridgnorth, to Highley. So, and they bring us directly the experiences of those communities and help steer our work. And they are invaluable to us. Now, as part of the government's plan to take our functions into health and social care, that is not part of that piece of work. They are not. They will carry on using the public in the way that they choose, but that independent steer and that independent voice of the public is at risk of being lost. And the key role that we are very concerned is going to be lost is our volunteers do something called entry review, which is where we do DBS checks, we give them training into what entry review is, but also into adult safeguarding, DOLS, the Deprivation of Liberty safeguards, the Mental Capacity Act, so that when they go into services, and that can be care homes, hospital wards, GP practices, they can, they don't have to be an expert in those services, but what they're looking for is this a service that I want to go to? Is this a service that I want to use? And that is a very unique perspective that we bring. We don't look at the paperwork, we don't look at the fire regulations, we don't look at the staff room and how well people are being supervised. What we look at is the person's experience of using that service. And under this legislation, that is a function that will be lost. And people can feel incredibly passionate about this. Our volunteers, they can be any part of our community, but we often attract people who've worked for their whole life, either in the NHS, they've been teachers and head teachers, they've been pharmacists or, parts of ambulance crew. So these are people who know a lot, and they want to give back. And one of my big concerns is that opportunity will disappear if this health bill goes ahead in its current form. We are also a statutory member of the Health and Wellbeing Board, and the advantage of that is that I can bring the voice of the public direct to a public meeting where the providers are sitting around the table and say, what are you going to do about it? And again, that voice will be lost at that Health and Wellbeing Board. And we are fortunate at the moment because as our NHS has clustered with Staffordshire and Stoke-on-Trent, partly because of the way we've conducted ourselves over the last, however many years it is, 12 years, we've retained a seat at the table, which means that we can also bring the public voice directly to them. What I've seen as Chief Officer over the last the whole time I've been doing it really, is that we can play a key part in bringing together people who are working across health and social care. the amount of times that I've been to a meeting where the same conversations happened amongst council employees, and I've then gone to an NHS meeting and they're talking exactly about the same things, and I've been able to put those two people together and say, come on, work together. I remember when they announced the integrated care system, and I got so excited because I thought, this is it. The chair, I spoke to the chair of the Integrated Care Board, which is NHS Shropshire, Telford and Wrekin, and I said, you know, I'm an ex-social worker. I was the first social worker in Shropshire to work in a multi-agency team on prevention for children and families in 2007. So all these years later, they were talking about all this joined up work, and I said, you know, this about time too, you know, without swearing. And he said, oh, you're so naive. And that is why I go to every single meeting of the Integrated Care Board. You know, I was at the very first meeting of that group when they were going to make it so that that board could vote for a motion without anyone from the local authority being there. And I contacted Tanya Miles and I said, you need to come to the next meeting and you need to make sure that the ICB cannot do that. So sometimes I might be the only person at that meeting, but no one from the local authority might be able to come, or nobody from the VCSE sector can come. And it's not my job, but I am very determined to make use of that seat at the table. And somebody needs to be there going forward in order to make sure that that is registered as a comment in an official public meeting. You realise I'm very passionate.
Just wrap up,
yeah,
please.
Yeah.
Thank
so one of the things that we are also concerned about is as our functions, which are that very high level function of patient and public experience goes into the local authority and to the NHS, is that until we are truly an integrated system, those voices are not going to be brought together. You know, every part of our system is financially challenged. They have priorities. I remember when the ICB first wrote their priorities, they had 96 priorities. They haven't got quite so many now, I believe, but even I cannot tell you exactly what those priorities are. But as they reduce their staff, I no longer have a route in to the NHS at the moment where I can share people's live experiences and say, can you sort this out now? I think we might have encountered that, Dawn, when you came to me with that issue. I'm not confident that our system at the moment can take on this responsibility. And also, I'm not confident that they can identify the gaps in services if it's anything beyond the priority of that moment. So, because of our independence, because we're at the end of the phone, anyone can contact us at any time about any issue, and I can then ask a question. But not only that, I can also escalate it to the Care Quality Commission, NHS England and Health Watch England. So this is a very fortunate position to be in, and I have had to do that over time. And because I might be the only person around a table who can ask the awkward questions. Fortunately in this area, we do have Helen Morgan, who is MP for North Shropshire. Now she at the moment is the Lib Dem lead on the Health Committee who is talking about this bill. Even though we are a completely non-political organisation, and I have a fear and abhorrence of politics because I just don't understand it, I'm very grateful that Helen Morgan is going to meet with me and members of the network later, because she is the only person who has included amendments to that bill from the beginning, and that includes not getting rid of the independent patient voice. And so we are encouraging everyone in Shropshire to write to their own MP to ask them to reconsider this decision going forward. This is not about saving Health Watch, it's about saving that independent voice, that local knowledge, as particularly as the NHS becomes responsible for Shropshire, Telford and Wrekin, Staffordshire and Stoke. We need a local presence on the ground, talking to people, and addressing digital inequality. Sorry, I think I should become MP now, but anyway, I'm just so passionate about this, and I really would appreciate your support.
Thank you very much, Lynn, for your passionate defence of the independent patient voice, and I think we all would wish for that to continue. I would say that it's important that people contact their own MPs, and there's more than one in the county, for balance. And that I know that the Health and Wellbeing Board and the Integrated Care Board are working hard to try to maintain the independent patient voice within Shropshire, Telford and Wrekin. And so I don't know whether, Rachel, you've got a brief comment to make about that?
Sorry. Thank you, Chair. And sorry I didn't introduce myself before. I'm here in my capacity as Exec Director Health, Wellbeing and Director of Public Health as well, which is linked to that particular last item. Yes, so I obviously sit on the Health and Wellbeing Board as Chair, as you've said. The Health and Wellbeing Board, with Healthwatch as a member, have written several times to the Secretary of State to express our concerns about the loss of the independent patient voice. We've had a response back that confirmed that this would that it would continue, just confirmed already what we knew. However, we have written back again and once again expressed and continue to express our concerns around this, and likewise the loss of funding that will be associated with that, as we understand it at the moment. We have started to get together, we have brought together a small working group, as was requested at the Health and Wellbeing Board of Partners, to look at what currently is provided statutorily that we are mandated to provide across adults, children, social care and health. And the gap, as Lynn said, in terms of what isn't a statutory provision at the moment and through the bill, is certainly around that patient independent voice, which is where we have the concern. So those conversations are ongoing, looking at opportunities to potentially align resources around filling that gap around the independent voice. I think what came through very strongly is that not everybody feels comfortable to go and speak to our organisations. We might commission independent services advocacy, but if it's linked to one of our services, that people won't always feel comfortable to come forward, and that's again one of the added values of having Healthwatch. We're very lucky to have the Healthwatch we do in our system, and we continue to strive to look at that. It is an issue for us. It's the loss of resources around this is a real challenge when everybody's as pressed as they are, but everybody recognises the value and is continuing to work together. I don't have a resolution at this point in time, but we are still continuing to work through that.
Thank you, Rachel, and hopefully a conclusion will come before the time of potential ceasing of the service, which I understand would be April 2027.
Yes, so in Parliament, the Health Committee, who are responsible for talking through every part of this bill, that is happening now, and that is due to end in a week or two. So that's why it's so important that people have their voice heard as quickly as possible. Some of the amendments that are being put forward is to remove the abolition of Healthwatch England and the local network. We are not convinced that argument will stand, but what we would like to see is that change in emphasis towards that independent voice and how the public are involved in service redesign and service commissioning. We also know that Andy Burnham, as Mayor of Manchester, was extraordinarily supportive of Healthwatch, and like our Health and Wellbeing Board, he wrote in defence and support of Healthwatch. So we're hoping that should whatever happens, that he will continue to support us going forward. So it's certainly not a done deal. And we are also, as a network, not only communicating with our populations, our councillors, our MPs, but in all the other areas, speaking to members of the House of Lords as well, because there is also some support for us in that setting. So it's not a done deal, but yeah, we can't lighten up on it. Yeah.
Thanks very much, Lynn. And I'd just like to add one thing that hasn't been discussed, and that is that staff who have concerns, who may have worries about going to their own organisations can come to Health Watch for some independent help in signposting them to the right regulators or those people who and organisations that may help. I think we're going to have to move on.
Yeah.
So, Dawn, did you have one very burning question? Very quickly, we need to move on to the last.
Yes, I know. What member involvement has there been on the working group that you've set up so far? How can you better use members as an independent voice, because we are there on the ground talking to the people in our areas? And how can you better train and support members to be better independent advocates if we are faced with the closure of Health Watch? Thank you.
So I think Lynn might want to answer the questions about how Health Watch engages with members. In terms of the group, it's a subgroup of the Health and Wellbeing Board. So obviously members are on the Health and Wellbeing Board. The ask was to go away and map what services we currently have. That hasn't been brought back yet, but it will be brought back to the Health and Wellbeing Board. And we did discuss that in Health and Wellbeing Board workshop where members were present as well. So I think once we've got that, we need to make sure that we share that more broadly. At the moment, the mapping shows that, and we haven't completed it, that each of the statutory organisations does have services that it must provide around advocacy, around patient engagement. I think, as I said, our concern is, which is what we'll bring back to the Health and Wellbeing Board, that that patient voice bit is missing from all of those. It's not statutory, it's not mandated. That does leave us as organisations with a challenge because of funding.
Just a final add from me, tomorrow we publish our annual report, and so despite all the many changes this year, we've reached so many different groups across Shropshire, so I will share it with this committee so that you can see the sorts of work that we've been doing. But also in Shropshire, we also provide the Independent Health Complaints Advocacy Service. And the reason we got that is because it's so helpful as Health Watch to be able to see the sort of issues that are being formally raised within our system, particularly after things like the Ockenden work. I mean, right at the beginning of that, we were contacted by families, but we'd been set up because of the timing. We weren't there right at the beginning, and we probably could have played a greater role. But throughout that process, we were supporting people to have their voice heard, either directly or indirectly through Ockenden.
Can those anonymised findings be shared with this board, this committee?
Of which one, sorry?
You were just talking about that you had the report on the issues that have been identified. Can those anonymised findings be shared with us so that we're aware of the sort of issues that are constantly being raised, because we might be able to take it further?
Yeah, and that's why I'm a co-optee on the joint HOSC, but yeah, definitely there's more that we could bring to these conversations.
Thank you very much. And can I just ask from the chair that the deliberations of the Health and Wellbeing Board do come to HOSC before the final decisions are being made, and in advance of when Health Watch would be scheduled to no longer exist, so that we can have an influence on the deliberations and know what the resource offers are going forward. Thank you. So we'll move on to the. Thank you very much, Lynn, for your very passionate update. So we move on to the next item, which is update from the Joint Health Overview and Scrutiny Committee, and this is from myself, and I just need to get to my bits and pieces. You've got the information?
I can send it to you.
No, you already did, I think.
I did, but it's fine.
Yeah.
It's awesome.
Excuse me. Right, so I think I've found it. So there was a joint health overview and scrutiny committee on the 18th of May in Telford, and we received a 6-month update on the winter plan across Shropshire, Telford and Wrekin, and the system reported that the plan had been assured ahead of the schedule, and that there had been a more coordinated system-wide approach with earlier involvement from partners such as primary care and pharmacy, alongside additional capacity within hospitals. And members welcomed the overall progress and the improvements seen ahead of Christmas, but did note that the Christmas season remained particularly challenging due to staffing pressures and reduced service availability across the system. And clearly there's some information that can be, some lessons that can be learned going forward into the next winter plan. We focused on a number of specific issues, including vaccination delivery, delayed discharge, infection control, and the role of community pharmacy. In particular, members raised concerns around delays in vaccination delivery, particularly for schools and more vulnerable groups, and asked for further information. There has been some recent communication which hopefully will further improve vaccination delivery, which I'll come to when we come on to the work programme. And so the key message was the need for clearer and more detailed performance information to support effective scrutiny. And as a committee, we've requested more robust year-on-year comparative data, including admissions, particularly emergency admissions, occupancy and system pressures, so we can better understand the trends and performance over time. We received an update on community health provision, which is an area of ongoing development, of course, with work underway to bring forward a more comprehensive strategy, covering neighbourhood teams, urgent community response and core services such as district nursing. The committee is asked to see this strategy along with any updated modelling linked to the hospital transformations programme as it progresses. Finally, we discussed feedback from briefing with the West Midlands Ambulance Service, which I personally wasn't involved with, and members noted some improvements in handover time and overall productivity, while recognising that sustaining that performance remains a challenge. And there was a discussion about the increased use of alternative care pathways and the importance of community services in supporting this approach. Further data has been requested to support ongoing scrutiny. There was a reflection on an informal session with the out-of-hours provider, Health Hero. Members were reassured by the service performance to date and agreed that no further scrutiny was required at this date, with ongoing oversight to sit with health and well-being boards. But I think it would be useful to have some kind of summary that this committee can look at. And overall, the focus of the May meeting was on systems of resilience, winter planning, and the continued shift towards community-based care, alongside ensuring that we have the right level of information to scrutinise these changes effectively. Thank you. So, I think because of pressure of time, if anybody's got any queries, can they perhaps email them to me individually? We move on then to the update from the Health and Wellbeing Board, which I think, Rachel, were you going to do?
Sorry, Chair. We're just making sure we joined up. Just in terms of the Health and Wellbeing Board, there has not been a Health and Wellbeing Board meeting since the last HOSC meeting. The last meeting that was in May was stood down, and the items on that agenda was postponed and was moved forward to the next meeting. So the meeting that is taking place next week will focus on the work around neighbourhoods, which I know is then going to come back to HOSC. There's also a focus on some of the Health Watch updates, so they're being brought through to the committee. And then there's a number of joint strategic needs assessment chapters that are now being brought forward to the Health and Wellbeing Board, including maternity services, the drug and alcohol joint strategic needs assessment as well, that will be brought forward, and the end of year better care fund. So they and also the 5-year strategic commissioning plan from the ICB. So those are being brought forward to Health and Wellbeing Board next week. There hasn't been a meeting since this committee last met, but we'll provide an update at the future meeting. But I know you get the agenda, but I just thought it's helpful to signpost you to that, and that will then lead into some of the future conversations here around neighbourhoods and other areas.
Thank you very much, Rachel. And in relation to alcohol. I've received a letter from our MP, Julia Buckley, with regards to training in relation to alcohol dependency, which we'll come on to during the work programme discussions. But basically, it's looking for increased integration of the various elements of the system and improved training. So, if we move on then to the last item, which is the work programme, I think that that those who are not members of the committee can be excused if they would like to go, but you're very welcome to stay to observe, but you've probably got other things to do. But thank you very much for coming today and for your valuable contribution. Thank you.
Would you like me to introduce you?
Yeah.
Thank you, Chair. So I'm Sophie Foster, the Overview and Scrutiny Officer who supports the Health Overview and Scrutiny Committee. So this item is an opportunity for the committee to take a structured look at its emerging work programme and agree where scrutiny can add the most value over the coming months. The draft programme that's been published before you brings together the topics identified at the strategic work programming session, which was held on the 9th of June, which you will see includes items from today as well as longer term item areas for you to review. This is an opportunity for the items proposed to be reviewed and included, and also that if there's any that you feel are not present within the current list, that they can be discussed and added and prioritised. The aim this morning is not to finalise every detail because of time, but to test the priorities, consider the most appropriate scrutiny approach, potentially for each topic, and provide a clear steer on the programme and how it should be developed. But I'd say, given timings that probably there's the opportunity to discuss how things may be done later, the priority for today is probably more around what order things are reviewed in and prioritised. Members may particularly want to consider timing, capacity, and where joint working with other committees, such as the People Overview and Scrutiny Committee, would be helpful. I know this has already been discussed in relation to put my teeth back into delayed discharge and inappropriate discharges. So, as I say, it's very, very much a working document to be reviewed, and it is wholly owned by you as the committee to be, reprioritised and added to as appropriate. Thank you, Chair.
Thank you very much, Sophie. So, perhaps Rachel, you could give us a little steer into where your areas of particular importance are at the moment, and particularly in terms of timing, and how the work of the Health and Wellbeing Board can integrate best with the HOSC.
I think practically, Chair, as was discussed in some of the work programming, one of the biggest areas which which will need continued development and engagement from the committee is around neighbourhood working in its broadest sense. So that has, I think the discussion was that should take some considerable probably time of the agendas going forward. And so, as I said, that this is something the Health and Wellbeing Board will also be looking at and helping steer, and there's a role obviously for this committee. So I think the timing of that at the moment is there's a meeting the next week, as I said, around the Health and Wellbeing Board where they'll discuss some of the neighbourhood work. This is an ongoing programme, obviously, as one of the biggest arms of the 10-year plan, and then it's been timetabled on this agenda for, I think, if I come back and look at it, for September, but I think the discussion was that would probably continue once that you'd have the first meeting of this committee, and there would be certain areas that you might want to look at in more detail. And linked to that is then the 5-year strategic commission priorities for the ICB, which will be routed through some of the neighbourhood work, and again, you might want to get into focus in some of those areas. So the other thing that's on here, which you've seen in the purpose today, both drug and alcohol services and the 0 to 19 were a big area of focus in the recommissioning, which the committee's already seen, and we can bring updates on those areas. The joint health and wellbeing strategy. Now, actually, the strategy does run until the end of 2027. But I think that early engagement and work to update the health and wellbeing strategy to make sure it reflects the 10-year plan, local priorities, some of the neighbourhood work, and there's a clear drive that would be along the lines of the Marmot principles, coming back to the 0 to 5, the wider determinants of health and all of those issues. So again, as we start to work through what that will look like, refreshing some of looking at the current strategy, updating, looking at some of the key performance metrics, I think that would be really important to make sure that this committee has strong engagement within that, but that would be, I would suggest, towards the end of this financial year because of the timescales. So there's a huge bit of work to do around neighbourhoods and engagement, and then the joint health and wellbeing strategy. The other thing that's on here, just as I mentioned earlier, so just to loop back round to it, is the public health work. We usually do an annual briefing outside of this meeting to members, and then if there's items that come through that you want further, then we may put those onto future work programmes. So drug and alcohol services or 0 to 19 services, you may want to do a deep dive, recognising the committee can't do everything, but we usually do that. So there is the Director of Public Health Annual Report, but there's also the update in terms of public health more generally, and some of the funding that we receive and the outcomes that we are delivering, recognising that it's not just for the public health team to deliver, it is an organisational and system-wide commitment. I think we've talked about the patient voice within that strongly, but I think there was quite a bit that's come up previously around children and young people's mental health, and again that's something that we've very much looked at jointly with People's Committee and potentially Joint HOSC. So just to highlight those, but I think the big areas are definitely neighbourhood health and probably the strategy.
Thank you, Rachel, and I would strongly recommend, if you can, to attend the Health and Wellbeing Board to be appraised of the deliberations that are taking place and the decisions that are being made, because we'll be looking at those proposals in September. Do you remember when it is, Rachel? The Health and Wellbeing Board next week?
It's always a Thursday morning.
Thursday morning. Thank you.
But what I would say is these are the start of discussions. This is not anything that's been set in stone. This is trying to look at what neighbourhoods means for Shropshire in the context of all the work that's already ongoing. This is about knitting all of those programmes together. It's very much the start of it, which is why there's that importance of that engagement of members, HOSC, clinicians, etc.
Yeah, and we previously discussed about member engagement in this process, and in particular the area that individual members represent, and how that feeds into the development of the hub in that particular area that you represent, and how your input can help, and how you can learn what is planned. So I think that's going to be really useful.
Just from a practical perspective, for any members who are not able to attend the Health and Wellbeing Board, because it tends to be in the day, it is live streaming and recorded in the same way that HOSC is, and myself and the officers supporting that work together. So you'll be provided with an annotated agenda, so you'll know the timestamp of when certain items are in that, so you can then be able to watch through at a later date if you're not able to attend. Thank you, Chair.
So I just want to go through one or two things before we go into further. And the letter I've received from Julia Buckley with regard to the stigma and training in relation to alcohol dependency across health and partner services. This has all been forwarded to you in your emails, so you should all have this. And this will form part of the discussions we have about alcohol services and drug services. And so that, I think, is part of what we've got in the programme, at least from memory. I thought it was. Can't actually see it.
Yes, it is on there.
Is it within? That's it. Yeah. Community drug and alcohol services. So I'll write back to Julie Buckley, indicating that we're taking her letter on board. We've received an ICB stakeholder update with regard to what they're planning in terms of merging with Staffordshire and Stoke, and so we think it'd be useful for them, for the system to tell us what practically that's going to involve at some point during the year. We had an update on vaccines from the Integrated Care Board again, and I think that's been cascaded to you all. But it's quite useful to see how the vaccine programme is being delivered across the health sector. And vaccines, I don't think is one that we'd chosen, but it is a favourite of mine because I think the potential benefits are large in relation to the expenditure of both resource and time. So, with regard to the workflow, have you any template that we could go through that, apart from this graph we have here, of what to put in relation to our capacity?
There is a process and a checklist that we would offer to support members with in terms of prioritisation. I would suggest that probably given the time, that wouldn't be possible within the 15 minutes. So what I'd probably suggest is that using this time as an opportunity to gather any other topics, or particularly for members to confirm their feelings of prioritising certain topics, and then to convene another meeting of the committee where they could then be gone through with that process and refined that way, if that was agreeable, Chair.
Thank you, Sophie. So, Dawn, you had a point or a question?
Yeah, with the I'd like to see some actions actually coming out of this, and I'm seeing too much just report to committee. Like from today, we've had the 0 to 19 report to committee, but there were a couple of questions that came out of that, so I need to see those documented going forward, so that we're actually an allocation of responsibility that it's happening. There were questions that I had with regards to Health Watch. The, again, verbal update that weren't answered about how to better use members as independent voices going forward, as we're likely to have to do. So I'd like an action on that to see, what are officers, the council, going to do to ensure that we're properly engaged. I think the point that Councillor Bentley brought up about hubs and assets is absolutely vital and needs to be seen in that overall context of how we're moving forward. How are you going to better train and support members, like a lot of the knowledge that Lynn has got? How is that going to be given to us to help support us, being advocates, regardless of whether Health Watch goes, sadly, or not? I think that's something that's quite important. With the drug and alcohol service, well, commercial sensitivity can be respected, as it has been with the Quay contract, within offline task and finish groups. So that is certainly something that we could be looking into, because again, just coming back with, we're just going to tell you what we've done, it's a bit late for scrutiny at that phase. So, we need to be involved at an earlier stage, yes, back to member involvement. So those are the key ones that I've got at the moment.
Sure. I think during the discussions, we did identify specific actions that the officers were going to come back with. But there are actions for us as well, which we're noting. Were there any other issues, any other topics that people felt that weren't included or should be given particular priority, apart from the ones we've identified? Councillor Andy Davis.
No, not additions. We're going to review the provision we spoke about this morning. There's far more questions about that I wanted to ask, obviously with the time limits on it, to see how that commissioning process is going through it, what's happened prior to the commission, just like you've identified, where's that data analysis basis, where's our starting point, right to the final commissioning stages. So I think that is such a major issue. You're just looking at the health and well-being of children from birth onwards. And I think those are the ones we really need to be asking questions along the way to ensure that what's actually happening on those lovely PowerPoint presentations is actually happening on the ground as well.
Yes,
yes. But I do welcome that. It is on the agenda. So
triangulation.
Absolutely.
With member and user experience. And so perhaps we'll bring you in, Tom, in a second. So perhaps we should, for this topic of the health work programming discussion, actually have a workshop to go through it, because this is going to take some time. It's probably going to take 2, maybe 3 hours to do it, so that we're comfortable with what we're going through. We don't miss things out. We get the prioritization, we get the timings right, so that we don't end up spending too much time on some things and that have got limited outcome, or that we can influence in too little a way in terms of adding extra value. Tom.
Thank you, Chair. You've taken some of the words I was going to use then as well, but I think that there's a real opportunity for members. So like Councillor Davis has just identified, he's got a series of questions or further things he'd like to talk about. I think there's an opportunity for members to not wait for committee meetings, but to go and have those conversations with the officers, the portfolio holders, to find out a bit more. And then if you are going to do that additional session, which I know Sophie mentioned and you've just referred to, Chair, bring some of that back in to inform that conversation. But you meet at the moment on a scheduled once a quarter basis, 4 times a year. You can put additional meetings in if you need to for public meetings held in public. So use the time to explore that a bit further, and then equally find the right opportunities to pursue the areas. But I think the point you made just then, Chair, is the important one, which is what are the opportunities to add value? What are the opportunities to meet those sort of 4 key purposes of overview and scrutiny, including being the voice of communities, which leans back to the piece on the Health Watch and the point that Councillor Hoosman's been raising as well, in terms of how local members can be the voice of their community in scrutiny, but and in general. So probably plenty of things to bring forward as well in terms of member development and briefings. So lots to work on around the work programming.
Thank you, Tom. So has anybody else got any? Councillor Lovely.
Yeah, I know we've spoken about this, but I think that as we aim to build a children-friendly Shropshire, I know that children is within this work programme, but as chair of All About Youth, it's also children's mental health and well-being is coming up more and more often. So I think I would like that to be a specific focus, moving forward. So,
and I think that's part of the 0 to 19 programme that we've had this discussion about this morning.
Yeah, I'd like to highlight it as quite a specific area.
And I know that CAMS is a specific contract for that. Rachel.
I think I was just going to add, so obviously it's only part of the 0 to 19s, as colleagues were saying, it's more the well-being bit, it's the universal offer. I think the idea was that perhaps it needs to be more broad topic and perhaps involving People's Scrutiny Committee as well. Yes, CAMS is part of it, but it's actually a range of services, isn't there, beyond that, so I agree. I think there was a suggestion that could be a joint topic that brought everybody together, and actually we did look at mental health previously at HOSC, but I think it's an opportunity to join up all of the offers because it's quite complex and there's a lot of support out there.
Are you suggesting a separate workshop with People's Overview and Scrutiny Committee?
I think because it was so cross-cutting and it obviously brings in a broader range of services, it isn't just the 0 to 19, as we said, that's only a small part of that. It's signposted to more special service. There's CAMS, but there'll be for community services, there's a whole range of offers there. It overlaps some of the neighbourhood working, but I do think it also involves People Overview and Scrutiny, so it's potentially one to do jointly.
Yes, and perhaps at a separate time than the workshop that we plan. Because otherwise we're going to be discussing areas that the People Overview and Scrutiny Committee won't have much direct input into.
But as Vice Chair of the HOSC, maybe that's something I can take forward. So
yes, thank you. So Councillor Andy Davis.
It's just making sure that we are very specific on the role of the school nurse and the mental health issues. They're 2 very different things. I think we have to be clear of those 2 areas within the whole commissioning programme really as well.
Yeah,
you would agree, yeah?
I agreed, and I think it was telling that that Naomi and Anne-Marie did say that there was there wasn't an accurate perception of what they were about, and I guess that's down to communications on behalf of the department, not on the receiving end in schools. So if there's a concern that their function isn't known, then perhaps that's a communications issue for public health.
I think it's probably an issue for everybody really, in terms of really being clear about what the service is, what it can do and what it doesn't do, because these are partnership services that often the lines are blurred, and I think, as I alluded to, some of that changed through the pandemic. So I think there's an opportunity to reset some of that, and I think the team are trying very hard, but again it comes back to being really clear with everybody. I think it's everybody's role. I suppose what I would argue, yes, we are communicating some of that, but we know that expectations, understanding of the services we need to keep doing that and emphasising it. I think it's joint.
Thank you. So I think we're saying there should be a separate meeting with POSC. Is that correct?
Yes.
Yes.
Yeah.
Thank you.
But as far as setting the work
with regard to the 0 to 19 Healthy Child programme, that doesn't stop us discussing it initially. Any other? Thank you. So, Colin Taylor, you're online. Thank you for waiting.
Because I've written Colin Taylor. It should be Colin Stanford. I'm making up people.
Sorry, Colin. Different Colin. Colin Stanford.
Change my name and become virtual at the same time. It's a plea, really, that patient voice is quite a long way down the list, but given that all that we've heard this morning, it's fundamentally important. It's not very well formalised at all. I've spent 40 years as a professional and as a commissioner trying to improve health services. I've come to realise that patients are the people who will probably ultimately change things for the better, not us sitting around this table, these tables. So I really would put a plea that somehow we do try to fly a flag for patient voice and look at how we can do that effectively.
Thank you, Colin. I think we're all sold on the critical importance of the patient voice and how to maintain this going forward, whatever the decision of the government is, moving up to April 2027. And hence the Health and Wellbeing Board has been working with with stakeholders to continue this, even in the absence of direct funding from the government.
Thank you, Chair.
Councillor Beverley-White.
Thank you, Chair. I'm assuming that this has been done in alphabetical order, otherwise women's health shouldn't really be at the bottom.
Thank you, Beverley. As a gynaecologist, I fully agree, and it is not because of prioritisation. Thank you. Councillor Dawn.
Thank you. Given that, particularly this year or the next few years, it's all about the money. And the delays that happen and the time it takes to get information, we've got September for neighbourhoods. Well, there's a whole lot of work that we could be doing, a whole lot of information we could be asking for to make sure that we're in a good position in September, rather than waiting for September and then saying, oh, actually, we need X, Y, and Z. And I know you've, Bentnick, have brought up the finances of it. We need to get ourselves into a position where, I want to see, right, these are the hubs that are being talked about. This is the amount of money that is going to be coming from the NHS towards that. These are the services that they're talking about, not necessarily finalised, but this is what we're talking. Oh, sorry. No, that's Heather. Sorry, Heather. That, these are the services that we're talking about putting into that hub, and then how that interacts with the local authority. Just really clearly, not in a great big 174-page report, but, hub, location, money, services, so that we can then start, getting down into the nitty-gritty of it.
Yes.
Please.
Exactly, and I'm sure that Rachel will tell us, but we all feel that it's of critical importance to be kept up to speed with the decisions that are being made with regard to the rollout of the neighbourhood health implementation plan locally in Shropshire, in the 18 areas that are established.
And have a chance to challenge and question.
Thank you. Rachel.
I think that's absolutely the purpose of the sessions and having these in the diary. I think it's fair to say, firstly, this is why we need a whole conversation. Neighbourhoods is more than hubs. It's much bigger than that. In terms of the geographies, it's not, there's, you know, the geographies vary, so there is 18. We use 18 geographies. There's different geographies that are used, and that's very complex. The plan is developing, and I think the whole purpose of it coming to Health and Wellbeing Board Hospital is not going to be something set in stone. It's to keep developing that iteratively. This is a 10-year programme, isn't it, with the NHS? So I think I understand that everybody wants to be actively involved and engaged, and that was the purpose of putting it in September and then putting it again, because what you're not going to get in September is a finalised plan. What we know is what nationally they're being told that must be delivered from neighbourhood health side of it, from the NHS, but there's also lots of other aspects, children's reforms and others that need to be brought together. So it's an ongoing iterative programme that absolutely everybody needs. Member engagement, needs clinician engagement, needs community engagement. It's a huge piece of work, so there isn't something that's set, and it needs that to be ongoing. So I think the timing around some of this is because there isn't something set in stone at the moment. That's developing.
Fully understand that, Rachel, but I'm sure you'll understand we're all impatient to get on and see the implementation plan. And I'll allow one more question, but just before that, I'll just remind everyone that they've had an email forwarded to them from the ICB from the 17th of June 2026, saying that they were needing to implement reduced running costs of £19.55 per head of population. So that's a background to some of the financing, and a critical statement that place-based partnerships and neighbourhood teams will be at the heart of how care is delivered. So place is important, it's vitally important going forward. Even though we might not want to call it a hub, it might be a different place, but place-based partnerships are the key phrase. So I'd leave the last question or comment to Councillor Davis.
Just making officers aware, really. We want to be fully engaged in this process. So rather than leaving the item to the actual agenda item, the more information we can have, like Councillor Husman said as well, prior to that meeting, we want to do the work in between. We don't just leave it to the meeting to ask the questions and send it your way. If we can have the information before, it might be a members' briefing on areas. So neighbourhoods, bring us all up to date where you are prior to the meeting. So when it comes to the meeting then, we can ask pertinent questions and not just the questions which we should know the answers to already. And I think that's applicable to every issue we now look at every committee, basically, isn't it? So we can do a bit of background, we can get our information right and the facts right prior to coming to the scrutiny meeting itself.
Yeah, exactly, Andy. And members will know that we've been trying to ensure that that those presentations are sent to officers within the regulation time period, which is 8 working days before the meeting actually is due to take place, to give members the time to look through it all. Unless there's something which is urgent and it's unavoidable that it doesn't come in that regulation time period, then it will be dropped from the agenda for this HOSC if it doesn't come in the regulation time period. If it's 2 seconds.
Also, by having this information in advance, you in your reports then, we might not want all the information. We might just want to focus, for example, on mental health. And say, can we just focus and scrutinise this area? The other areas, we're quite happy with what's going. So it's saving you lots, we don't want thousands and thousands of pages, I wouldn't want anyway. It's just having the pertinent information so we can talk and scrutinise that. Thank you. Final point.
Thank you, Andy. And so the date of the next meeting is on Monday, the 19th of October 2026, at the same time. I'd like to thank everyone for attending today and for those who are online, and I call this meeting to a close. Thank you very much, everyone.